Today we're going to be talking about hyperkalemia. There are many causes of hyperkalemia. Some of the ones that you may know of are chronic kidney disease or acute kidney failure can cause that, as well as any drugs that affect the RAS system, like ARBs, any of the lisinoprils, and then as well as spironolactone, the potassium-sparing diuretics. If a patient told you they worked out and they're having signs and symptoms of rhabdo, that may also be a cause. Or if a patient's having tumor lysis syndrome, whether it be spontaneous or chemotherapy induced, those are also other causes. Some of the other drugs that can cause hyperkalemia are NSAIDs, TMP, SMT, and then Prograf, also known as tacrolimus, if your patient had any like a kidney or a pancreas graft from a donation, if they had a transplant. Heparin can also cause that, which is really interesting because a lot of patients in the hospital-based setting are on heparin. And the way that heparin induces hyperkalemia is through a suppression in the adrenal gland that suppresses aldosterone. If a patient is having any signs at all, any symptoms from hyperkalemia, it doesn't matter what the level really is, because if the hyperkalemia happens faster, then the patient will, likely show signs and symptoms of hyperkalemic emergency. Whereas if a patient, has CKD and they're just used to like a high baseline potassium, then they they'll probably deal with that high level of potassium better than somebody who it just happens all of a sudden. So we normally call it like a hyperkalemic emergency if the potassium is greater than 6.5, or if it's really any level like greater than 5.5, but the patient is having symptoms. So you want to ask them, are you having any chest pain? Are you having any like chest tightness? Or if they're feeling any weakness. So paralysis, weakness, any of these conduction abnormalities and, chest pain, those are all things that can manifest in a patient with hyperkalemia. So the reason why the hyperkalemia actually causes these conduction abnormalities is because it reduces the resting threshold. So it decreases the impulse conduction, it slows down, and it can lead to a lot of different types of arrhythmias. So some of the EKG changes, you'll see tall peaked T waves, you'll have a shortened QT interval, your QRS kind of starts widening, your P wave gets smaller and smaller until it disappears, and you can go into that classical sine wave pattern that they see. So once you have the sine wave, your patient can, you can have VTAC, VFib, and you can flatline and your patient can die. So what do you want to do so that your patient does not die on your watch? You want to make sure that you stabilize the heart. That's the most important thing that you can do. So you give them calcium gluconate, and that stabilizes the heart. You can give them calcium chloride, but that is not as popular because it causes some irritation at the injection site. You want to make sure that you can give the patient insulin, because insulin puts the potassium into the cells through a sodium potassium pump in skeletal muscles. And if your patient is, if their glucose is not higher than 250, you want to give them glucose with that so that you don't give them hypoglycemia. So, but if it's higher than 250, you don't necessarily have to give the glucose for that. You want to give 10 to 20 units of regular insulin. And then other things that you can do but are not as fast acting is you can give them Kayexalate, which is it's a sodium polyestyrene sulfonate, and that actually exchanges sodium for potassium in the gut. And then another one that works through a similar mechanism is patiromer, which changes potassium for calcium in the colon as well. You can give albuterol, which works through the sodium potassium pump, and so it can be inhaled or IV albuterol. And you can give the patient bicarb, especially if they're acidotic, because the cell will excrete a hydrogen ion, and by doing that, potassium will go into it and the hydrogen ion will be neutralized. You don't want to give calcium and bicarb at the same time, because it can precipitate into calcium bicarb, and you know, that'll be bad for your patient. So those are the things that you want to make sure. Some important key points is, if your patient has chronic kidney disease, you don't want to give a high dose of insulin. Try to be very careful with how much insulin you give them, because again, insulin is excreted by your kidneys, and if you have kidney failure, you're not going to be able to excrete the insulin, so then your patient can undergo, you know, a hypoglycemia episode. So you want to make sure that you check, and that you're checking to see how the hyperkalemia is doing as well. Thank you. And if none of those medical management therapies work, then you can always go to dialysis. If a patient already has access, great, but if they don't, they would have to get access for the hemodialysis.